I want to make sure you guys understand all these effects, right, in terms of blood pressure control, in terms of the hormones, in terms of the enzymes. All right. So to answer your question, Ian, 3 zones. Good to know about all 3 of them. It's not that, it's not for the test, but good to know what they do. So I said 3 zones. And the best way to remember this is if you remember, right, GFR. And GFR stands for, glomerular filtration rate. So zone 1 is G, zone 2 is F, zone 3 is R. So GFR, if you remember kidney, you have the glomerular filtration rate, GFR. You should remember three zones on the adrenal cortex and what they are, right? So G stands for zona, right? Zone or zona. And G stands for glomerulosa. And that zone secretes aldosterone, right? Then you have F. So GF, F, zona fascicularta. And that zone is primarily secretes your glucocorticoids, primarily your cortisol, right? So this secretes cortisol. Let me say cortisol, right? And then R is zona reticularis, and that secretes your androgens. Androgens, particular DHEA, right? And this, when it comes to your testes or ovaries, are going to be converted to testosterone and estrogen, right? So 3 zones, the ones that are pertinent for this lecture is the first zone, zona glomerulosa, and zona glomerulosa secretes aldosterone, right, which is responsible for salt and water retention. But the other ones are also important to know, right? In this cortex, right, we see 1, zone 2, zone 3, right? And if you remember GFR, glomerulosa fascicularta reticularis, that's 3 zones. Zone glomerulosa secretes aldosterone, fascicularta cortisol, R is androgens. Okay, hopefully that answers your questions. I'm not gonna be asking you, on the exam about these zones, all that stuff. It's just good. It's good to know in terms of your A&P. All right, before we continue, right? Before we continue the lecture, I just want to make sure you guys, clear about the major stuff, right? I want to make sure you guys understand, function of renin, function of angiotensinogen, function of angiotensin 1 converting to angiotensin 2, and then the effects that angiotensin 2 exerts, right, on the body, right? What does it do, right? About the blood pressure regulation, vasoconstriction, about stimulation of aldosterone for salt and water retention. All of that is clear. If all of this is clear, then we're going to proceed to abnormalities or pathology, I should say, and also the medications, which are important. But you must understand the normal before we go to abnormal. All right. So if no questions, right, we're going to continue with the abnormal problem. So imagine the following situation. So let me draw it here. Imagine we got the following situation. We have a guy, right? And you came in and you assessed him and you determined, right, he has a 3rd-degree heart block. And instead of doing a 12-lead EKG, you started pacing him. You took him to a non-cath labable facility. You took him to the closest hospital. They don't have a cath lab, right? And you paced him. And then, the doctors came in, all right? They called cardiology consult. They came in 3 hours later. They stop pacing. They do a 12-lead EKG. All of a sudden, they see, oh, this guy's having a heart attack. They have a STEMI. And they said, all right, we got to transfer him. They call a private ambulance company. They put him on the ambulance. They take him to the cath lab. And, all this time delayed his, right, stent placement. So a lot of his myocardium died, right? So he was in cardiogenic shock, but thankfully, they were able to recover some of the myocardium. And so he had a heart attack. He was in CCU, and then they discharged him home, right, with a lot of myocardium that's no longer functional, or we could say, right, lost secondary to ischemic and to myocardial infarction. And he's being discharged home, right? So in the short term, right, the same mechanism of this, right, of this renin, angiotensin, aldosterone system were good. Why? Because in setting of a cardiogenic shock, you have low blood flow, and we want that, right? We want this vasoconstriction, right, from the angiotensin and all this. But now imagine we have the following situation, right? We have a guy right? And let me draw his circulatory system here, right? So we have a guy, and he has suffered the heart attack, and I'm going to say capillaries here, and it's going to go into the venous system. And again, we're going to draw a lung here, right? And we can't forget about our kidneys, right? Which is going to say the kidney is going to be here, right? So same diagram as before, a little more simplistic so you guys can understand. So the following is occurring, right? So he had a guy, he had a heart attack, discharged home, right? And now there's, several days, weeks, months, right? He's now at home recovering. So the first thing that's going to happen is this, right? Do you think he can generate as much tension? Like, can his heart contract just as well, right, as before the heart attack? Or now it's contracting poorly?
Contracting poorly.
All right, contracting poorly. So in the initial phases, right, his cardiac output is diminished. So as the blood is flowing through here, right, as it's coming to your renal circulation, the blood flow is going to be diminished. And what this will do, it will trigger, right, the kidneys to consistently secrete renin, because as we said, right, if we're looking at this diagram here, as it's coming in, less blood flow, these Pol-Cason and maculodensa cells, right, baroreceptors, chemoreceptors, together they're called juxtaglomerular operators. They're sensing less blood flow, right, less blood pressure, so they're constantly secreting renin into the circulatory system. So now the same thing is going to happen here, right? More renin is going to be in the circulation. So as the renin is coming in here, the kidney, right, is always, right, unlike renin, which is secreted in a state of low blood pressure or low flow to the kidneys is always having this angiotensinogen in your blood. There's always there. Why? Because this is an active, right? We said this is an active protein. And what's going to happen, right? Renin is going to come with this angiotensinogen. It's going to convert this into angiotensin 1. And then as it goes through the lungs, right, through the ACE enzyme, is going to now make this into angiotensin 2, right, angiotensin 2. And this angiotensin 2, as we said, right, is going to become, systemically circulated and is going to cause profound, right, vasoconstriction, right, in your arterial side, and is going to stimulate aldosterone. Now, let's see what happens in the long term of these patients, right? So imagine I'm going to draw like a little graph for you guys. So let me do it like this. We're gonna say, right, your heart, right? Your heart is pretend your heart is like a donkey, right? This is the head, legs, and it's carrying the blood, right? So this is your end diastolic volume, right? And it's going to carry it up this cliff, and it's going to leave half of it here, and then it's going to return back, right? Usually, right, you guys remember, right, we talked about your stroke volume roughly being about 70 ml, right? Your end diastolic volume being about 140 ml. So let's say the preload that comes in here to your heart is about 140 ml, and then your heart contracts, so what it brings out is about 70 ml here, and then it's going to make its way down, right? So this is what happens normally. Now, with the effects of angiotensin 2 release of aldosterone and salt and water retention, right? All of a sudden, this amount of end diastolic volume is going to increase. Why? Because if I have angiotensin 2 and is going to now work to vasoconstrict both my venous side, venous tone, I'm going to have more blood coming in. So my end diastolic volume will increase. Does that make sense? So as more angiotensin 2 is coming and affecting my venous side, this end diastolic volume is going to become maybe 240 ml. So all of a sudden, right, this donkey has to carry much bigger load up this cliff, right? So now it's overloaded, right? And it has to carry more blood up over there, right? Now, we said this person sustained a heart attack, so we said the contraction is not as good, right? So maybe the stroke volume is not as good, right? And now instead of having 70, right? Let's say it's 50. So your stroke volume reduces to 50. On the other hand, right? We also said angiotensin 2 is going to cause profound constriction of your arterial side. So these arterioles are going to get constricted. This is increasing your systemic vascular resistance. So it's increasing essentially your afterload. And it's increasing, this will increase your diastolic blood pressure. But increasing the afterload, what's going to happen, instead of having this donkey, walk up this cliff, this afterload is going to make this cliff go like that. And now this heart, right, this donkey, which was your heart, it's not as strong. We're going to say it's missing, it's one of his legs, right? And it's very upset, right? It's very upset. Because why? Now it has to carry way, way more blood, right? Because of this angiotensin 2 vasoconstriction and aldosterone salt and water retention that's now piling all this on its back, right? So we see all this is piling on its back. All of a sudden, angiotensin 2, which constricted these arterioles, increases the afterload. So my afterload is increased. I have to overcome much bigger pressure in order to eject the blood. And because I have a weak heart, right, that's not contracting as strongly, right, I can only eject 50 ml. So instead of having, right, a good ejection fraction, right, all of a sudden my ejection fraction is decreasing, right? So what's gonna happen with this patient? All over time, his heart is going to get bigger, right? It's going to get bigger. Why it's going to get bigger? Because it's becoming dilated because more fluid's coming in. Also under the function of angiotensin 2, it's going to remodel it, right? Remodel the heart, right? We call it pathological remodeling. And, right, through this profound salt and water retention, right, eventually we're going to develop high blood pressure. Why? Because you have secretions of this renin coming with angiotensinogen, forming angiotensin 2, and also retention of salt and water, right, with aldosterone. So this is the major problems that we see, right? So in congestive heart failure, right, this is the outcome, right? And the same system, right, the same system that was helping us in the short term to preserve the blood pressure, preserve salt and water, you see how it's not helping us in the long term, right? So what do you think, how can we help this patient?
Maybe try a decrease in myocardial oxygen demand.
And how are we going to do that?
Give him medications, probably
And you could use, based on what you learned here, it doesn't have to be medications specifically from your protocols, but like overall the medications that you've been learning, right? So it doesn't have to be per se medications from the protocol right now. Like overall, what type of medicine, right? Seeing that all these receptors, all these enzymes, what medications may be beneficial to this person?
Furosemide.
Okay, so how will furosemide work, right? So perfect, right? So furosemide, as you guys aren't known, is a loop diuretic, right? So it's a loop diuretic. And what does it do, right? So let me go back to my nephron here. So in distal convoluted tubule, right? What is going to do, right? So we said there was let me draw it here. So we said there was a channel here. And the goal of this channel was sodium, potassium, chloride transporter. So basically this channel was transporting these channels out into the interstitium. So now I'll give you furosemide and I block this channel. So do you think it can pump out sodium, potassium, and chloride out? It cannot. So what's going to happen? The sodium is going to now move much faster, right, into your lumen, right? So, and water will follow along with it. So we will have nitriuresis, right? Nitriuresis, it's loss of sodium in the urine, right? And this and water is going to follow. So we'll have, right, more of essentially fluids being removed, right, from our body. How it's going to help us? It's going to take this, as I was drawing here, right? If I decrease the amount of fluid in my body, I'm going to decrease this end diastolic volume. So all of a sudden, maybe I cannot take him back to 140 liters, but I'm sorry, 140 liters, but maybe from this 240, I now go back, right, from 240, maybe I go back to, 160 mLs, right? So by giving you furosemide loop diuretic, right, we block that sodium, potassium, 2-chloride transporter. More sodium is leaving, so you have diuresis, nitriuresis, right? It's not being retained in your body. Water follows along, so I have reduction of this end diastolic volume. And so furosemide is a loop diuretic, right? And this is how it functions. What else can we do for this person? So we said number one, we could give loop diuretics. What else do you think is going to help this guy?
If you do a 12 lead and everything is okay, maybe you can give nitroglycerin.
And how will nitroglycerin work?
It also would decrease myocardial oxygen demand.
So yeah, it will decrease, but it will decrease the myocardial oxygen demand. It's going to cause vasodilation, or again, right? Less preload is going to be coming into this person, right? But let's look at the medications. Perhaps you are not, they're not in your protocols, but a doctor may prescribe this person, and you may see them, right? So imagine, right? You come in and you got this guy who has congestive heart failure, right? And all of a sudden you look at his drugs and you see these drugs. You see the following drugs. And you say, okay, I see these drugs, right? What are these drugs?
ACE inhibitors.
ACE inhibitors. And how will these ACE inhibitors help this guy here?
They will be blocking angiotensin 2.
They will not block angiotensin 2, but what they will do is, if we go back to my major diagram here, right? So what angiotensin, right, enzyme blockers, right, or ACE inhibitors will do, ACE inhibitors, right? They will block this enzyme. So they will block this ACE enzyme on these endothelial cells. So angiotensin 1 cannot convert into angiotensin 2. So angiotensin, right, inhibitors like captopril, enalapril, lisinopril, right, they act on this enzyme and they stop allowing this enzyme to convert angiotensin 1 to angiotensin 2. And now if we do not have angiotensin 2, right, are you going to get vasoconstriction? No, right? Because angiotensin 2 is no longer there. Are you going to have this aldosterone release, right, that was stimulated by the angiotensin 2? No, you won't, right? So you have less vasoconstriction, right? And you have less of salt and water retention. So what it's going to do, right, all of a sudden, right, is going to take this afterload that was increased. Now we're going to maybe go back to a normal slope, right? So by giving you angiotensin converting enzyme inhibitors, right, I'm going to now decrease the afterload. So number one, right, we talked about loop diuretics, furosemide. Number two, right, they could get prescribed angiotensin inhibitors, right, like let's say captopril, lisinopril. And their job is to reduce, right, this afterload. Is going to go back to more of a normal slope, right? What else? What other medications can I give this person? So far we look at this diagram, right? And actually, let me go back to this one, right? So look at the targets, right? So far we talked about ACE inhibitors. We talked about loop diuretics. What other things can you foresee this person receiving? Or what other medicine do you think may be beneficial? Doesn't have to be from your protocol. Any ideas? Or you could say, maybe if you don't know the medicine, where do you think they may be exerting their effects? Which part of the system?
Hydrochlorothiazide.
Okay. And what will that do?
It's a diuretic.
Diuretic, right? So yeah, so yes, hydrochlorothiazide. It works on a different part of the nephron, right? And it also, right, allows more of diuresis, right? So we already kind of touched upon this, right? What I'm saying is we already talked about, you know, that to reduce the end-diastolic volume. What I want to know is more of like effects of the system, like what else can it exert? Like what else can we target? Basically, what I'm saying.
Could we use beta blockers to block the
to block the contractility of the heart? So you can, but this doesn't really address the system that is here. So I'll tell you some of the drugs. So you see how we have aldosterone secretion, right? And the aldosterone was causing salt and water retention. There's a medication, right, called spironolactone. Let me draw it here. So this medication, it basically, it mimics aldosterone. It will basically go into this principal cell, right? And it will now not allow aldosterone to exert its effect. So spironolactone is going to come into this principal cell and it will basically mimic aldosterone, but it will not initiate this machinery to basically to allow aldosterone to exert its effects to retain salt and water. So if it blocks aldosterone from retaining salt and water, right, we have more sodium coming out from the nephron, right? So you have more diuresis. So spironolactone is a medication that's going to work directly on the aldosterone, right? Another medicine that we got, which is also pretty interesting, right? You see how we have these angiotensin 2 receptors here on the arterial side, on the venous side, right? On the cortex. So we have these medicines called angiotensin, right? Receptor blockers, right? Angiotensin receptor blockers. And the names of these medications, I don't know if you ever seen them, right? They called like Losartan, Condisartan, right? So what are these medicines? So Losartan, for example, is a medicine. It's an angiotensin 2 receptor blocker. So if I block these angiotensin 2 receptors, right, you guys can already infer, right? I'm not going to have this profound vasoconstriction, right? Venoconstriction, arterial constriction, and aldosterone secretion. So we can give them specifically, right, blockage of these receptors to essentially reduce their blood pressure. Also, angiotensin 2, right, it does pathological remodeling of the heart. So that basically causes the heart to have this dilation and all those pathologies that go along with congestive heart failure. So we stop this pathological remodeling by giving these angiotensin 2 receptor blockade medications, right? So this is another thing you could do, right? So, one, loop diuretics, ACE inhibitors. 3, we could give, right, a blockage of aldosterone. So we could give spironolactone. We could give 4, right? We could give Losartan for blockage of angiotensin 2 receptors. And what all of this will do is basically, the goal is to basically reduce this end-diastolic volume and get this afterload into the normal point. And if this does not improve, you know, all this stuff, then we could come in and give the person, right, things like digitalis, right, or dig, right, to increase this contraction of the heart. So there's more profound constriction, well, I would say contraction, so that maybe it will improve your stroke volume, right? So some of these things that are there to cause it. But, you know, what's important to know in terms of the renal system, right? The renal system is responsible, right, for this renin secretion, right? And in the setting of short term, like you have an emergency, like a cardiogenic shock, you have someone who is bleeding, right? In the short term, it's excellent, right? It's going to preserve our blood pressure. It's going to cause, you know, salt and water retention. But in the long term, right, it's detrimental for us because it's causing all these effects, increasing the afterload, increasing the end-diastolic volume. And so we want to control that, right? You're going to see these medications prescribed for these patients who have congestive heart failure. So when you arrive, when you see all this, it should trigger in your mind, right? Oh, I remember, right? ACE inhibitor, blocks the ACE enzyme. Oh, Lisinopril, they taking for that. Okay, let's see, right? Oh, they on Losartan, Angiotensin 2 receptor blocker, right? Same system. Oh, they're on Spironolactone, right? Blocks aldosterone. They're on Furosemide. They have a loop diuretic, right? So when you look at the medications, right, you kind of want to have an idea the target system they work on and the conditions the patient may be under, right? So sometimes if you get really good at this by just obtaining list of medications, you could kind of infer what problems the person may have, right? Any questions about any of these medicines we talked about and where they exert their effects? No questions? So the next thing, right, just to go through some of these slides that you're going to see, right, and some things that perhaps I have not fully addressed, but I'll explain it here. So now we see, right, the aspect of the liver where it makes the Angiotensinogen, which is a zymogen, right, and we said the juxtaglomerular operators, which is found in your kidneys. When you have a low perfusion state, low blood pressure, right, they will secrete renin. Renin is going to make this transition, right, Angiotensinogen to angiotensin 1. And in the lungs, particularly the endothelial cells, are going to convert it into angiotensin 2. And then we see all these responses, right? So on the adrenal cortex is going to work to secrete aldosterone. Some of other things I did not tell you about, right? It's also going to work on the hypothalamus, right, to increase thirst, so you become thirsty. And the other thing is going to cause the hypothalamus, specifically the posterior pituitary gland, to secrete ADH. So there's also receptors, angiotensin 2 receptors on the posterior pituitary, and AGH is going to come into the circulation. Anyone know what's the role of ADH? What does and antidiuretic hormone do? What were you saying, Angel?
I'm not really sure. I forgot, but I think I have an idea.
Okay.
It's going to I think it's going to work on the kidneys.
Okay, and what will it do?
The kidneys are going to secrete less fluids, so the body can compensate.
Very good.
Have a better blood pressure.
Very good. So you're 100% correct. So I'll come over here. I'll show you, right? So you're 100% correct in the distal convoluting tubule, right? And what happens is usually it's water impermeable, right? So, but under the influence of ADH, right? If you have ADH coming here, it's going to create these aquaporins. So it's going to create these basically water channels under the influence of ADH. And as the urine is coming through here, it will start to pull away this urine into the interstitium. So it's making urine more concentrated. That's why it's called antidiuretic, antidiuresis. So less fluid is coming out. So it's basically this ADH is going to cause these aquaporins to basically reabsorb H2O into the interstitium. So you're 100% correct, right? Urine is going to become more concentrated under the influence of ADH, which is secreted by the posterior pituitary gland under the influence of angiotensin 2. And this is, again, is going to help us retain salt, right? Retain water, right? And aldosterone, right, helps us retain salt and water. So this is, again, the function of this, right? And we see, right, what's the overall response of this, right? We said it is going to increase our blood pressure in order to maintain perfusion, right? So in the short term, this was great. So this is basically your renin, aldosterone, angiotensin system, or renin, angiotensin, aldosterone axis, I should say, right? And hopefully at this point, there should not be any, confusion. If there were any confusion before, I hope it's clear. Anyone still confused about the system? So hopefully that was clear.